We're going to go over three types of fractures that are pretty common in sports. One of them is going to be stress fractures. That's the first 27 slides. Those are more common than you think. I think they're missed more often than not. Understanding the criteria for how to treat a clavicle fracture operatively and non-operatively, and treatment options for humeral shaft fractures, particularly in throwing athletes, which I've actually had a couple since I've been here. So you get a patient comes in with activity-related pain. The first thing you want to do is a workup, location and quality. Where does it bother them? Is it something that only happens after they run? It's something when they wake up in the morning. Is it located in the groin? Groin typically is actually hip pain. I get a lot of patients that come in and say my hip hurts, and they point here or they point in the back. And those are two separate things. On the side is trochanteric bursitis, and in the back is more of back pain, sciatic pain. You always want to check past medical history because some of that can play a part. You want to ask them if they've had problems in the past. Sometimes patients said, oh yeah, I had to wear a brace when I was a kid. They probably had leg Calvé-Perthes disease, and that would be here if it was a hip problem. And they typically actually, even that looks pretty bad, it's amazing how long they can go with a hip like that, these young kids. How long their symptoms have lasted, if it's something more acute. You want to know anything that aggravates or alleviates this. Particularly if they say, oh, it hurts if I sit for a long period of time. I mean, Brett may talk, I don't know if what Brett's talking about. Maybe he'll talk about that kind of hip pain, but you could have impingement syndrome, any recent injury that they may have had, any change in their training. For stress fractures, that's really important. This is, you have a patient who decided they're in their 30s and they decided they wanted to lose some weight, so they started running, and they started immediately running 3 miles a day. And now their hip hurts or their shin hurts. So those are something you want to make sure you don't miss. What's their diet like? Are they getting enough calcium? I would say probably 40% of patients in this country are vitamin D deficient. It's maybe higher than that. They did a study recently. It was in looking at all trauma patients, and in trauma patients with fractures, I think the number was 60 to 70% of patients were vitamin D and calcium deficient. And for women, you want to make sure that their menstrual periods are regular. Let's see. So we did that. Oh, that's just the next. So this is just looking at a hip. You can't. In this one, you really can't see anything. And a lot of times with a stress fracture, you're not going to see anything. You can, but you're not always going to. So anytime a patient comes in with hip pain, we get this a lot. I get referrals who already have an MRI. That's great. I'm glad they have an MRI. But sometimes that's not necessary. I would say probably 20 to 30% of the time you can get an x-ray and you can see the stress reaction on an x-ray. And you don't necessarily need an MRI at that point. It's a very expensive procedure. And we still need x-rays anyway. So it's always good to get an x-ray before any MRI, in my opinion, for a bone, anything on the bone. Second line is going to be MRI, metabolic workup. If they do have a stress fracture and you do diagnose that, and I don't know if you can see this here. This isn't coming out very well from where I'm standing, but there's a stress reaction. I think it was on this side. Maybe I didn't. Maybe this isn't the one. So you want to look at female triad, eating disorders, amenorrhea, and osteoporosis. That's fairly common to see stress fractures in athletes, young women, and then. Metabolic workup is going to include many things. This is something that more people should be doing. There's a lot of patients, even young patients I'm seeing now, who are having problems. We've had a couple kids with fractures who've taken a while to heal, and they've had problems with low calcium, low vitamin D. They're not going outside. Their mom's covering them in sunscreen. Everyone's worried about the sun, but you need the sun. If you don't get sun, you don't eat the right diet, you're not going to get the vitamin D you need. If you don't get vitamin D, you're not going to absorb the calcium. So these are the basic labs, osteocalcin, bone-specific alkaline phosphatase, ionized calcium. These are all things you can order. 24-hour urine calcium, that's something we rarely order because usually the answers come with just vitamin D, PTH intact, and ionized calcium in a complete metabolic profile. These other labs are if you're more concerned about osteoporosis later on in life, but you can see osteoporosis at a younger age now. So differential diagnosis of these activity-related pain: labral injury, You can get a sacral fracture, sacral stress fracture. That is common, so it's not just in the hip. Sometimes you can get a sacral stress fracture, so you have to think about that. Osteitis pubis, that's usually tenderness to palpation over the pubic symphysis. You can get abductor strains. You can get an avulsion. This is a 30-year-old woman who actually avulsed a very large fragment of bone while playing sports, and we actually had to fix that. That was in kids, you don't usually fix it, but it was so large of a piece. She actually, when she sat down, she was uneven, so we had to fix it. And that was a pretty interesting case. I don't have the X-rays here today, but snapping hip syndrome, that's something else you'll see. They say their hip hurts. They'll say their hip dislocates. My hip dislocates. I can do it myself, and they'll pop their hip, and you can feel it, and it's the tensor going over the trochanter. Imaging usually confirms your diagnosis. Any of these, the right imaging will confirm your diagnosis. So, how do you treat a femoral neck stress fracture? Well, it depends on what side it is, but in general, as long as it's on the compressive side, meaning it's on the medial side, you can do toe touch weight bearing. You never want to go non-weight bearing with anything in the hip. If you do not put weight down, you are actually putting more stress on the hip than when you put about 20 pounds. Because when your hip muscles are so strong that when you lift your leg up, the muscles have to pull the hip into the pelvis, and you actually get more forces there than if you do 20 pounds of toe touch weight bearing. So that's the best way to neutralize the forces. You follow the exam and clinical exam monthly. You can advance their weight bearing based on their symptoms. Usually, 8 to 10 weeks they can return to sports. Usually by 4 to 6 weeks, if their pain's resolved, you can advance it. You repeat MRI. I usually repeat the MRI by this point, by 6 to 8 weeks, if they're still having pain, or if they're having increasing pain. So therapy can also be. Swimming's great. Standing in 3 feet of water is good. That's a good way to do limited weight bearing. Low resistance, you want to increase, this will increase their resistance in the bike as they continue to work, as they continue to heal. They can do upper body work, usually walk before running when they get to a treadmill. So this is a case example. This is a 37-year-old woman that I saw when I was up in New York. She had 2 weeks of right hip pain. She said it was in her groin. She ran 72 miles per week. And that's 100% true. She had actually recently increased her running as well. That was something that was interesting. And if you saw her, she was very frail, very thin. She was healthy, sort of, but I mean, she'd run 72 miles, but clearly she had nutritional deficiencies. And we couldn't see anything per se initially. We got an MRI, and that's the stress fracture. Okay, that's on the compressive side. It's not here, and so when she walks, that's safe enough to try non-operative management. So we did, and 6 weeks later, you can barely see it, but if you look right there, that's the callus that had formed. You have to look very close at these X-rays, and I know I'm kind of making up, but if you want to come up at some point, I can show you, but there's a little bit of callus right there, and that actually correlated. She'd healed at this point. She was doing well, and we had advanced her back to weight bearing. Okay, and here she is again, and you can see now it's gotten darker, and there's that bump there, and she's healed. Okay. This is a second example. This is a gentleman, 52 years old. He was recently retired. He decided he'd take up kickboxing and running. It's something you want to do when you're bored, you don't work anymore. He had right? So left hip pain with activity for 1 month, and now he couldn't walk. He got sent in, had no other past medical history. X-rays looked fairly normal. And that's not showing up, but there is stress reaction here. So that was another stress fracture. He had a repeat MRI. Now you can see it. At 4 months, repeat MRI, he still had a stress reaction. He still had pain. We really couldn't get him past toe touch weight bearing. Every time we tried to advance him, he had more pain. So that's him at the same time. 6 months, still having pain. Still had a stress reaction. So he got fixed. Okay. And he did well. Actually, he was back to. I think this was 6 months after that. This was 6 months after we fixed him. He was back to doing everything, kickboxing, running. All right, so tibial pain, that's something else you'll see. Shin splints, patients, running. The differential diagnosis here when a patient comes in saying when they run, their legs hurt, exertional compartment syndrome, that's something that you have to rule out. That's the way you diagnose that is you measure compartments after they run. It's really not the most fun thing to do. You can have medial tibial stress syndrome. You can have a fascial hernia. We've seen those before, so you have to think about it. You can actually usually palpate those, or at least I've been able to in the few that I've seen. And then athletes and military recruits. And why military recruits? Because usually military recruits, they go into their training and all of a sudden they're running, right? And they haven't done that before. So it's patients who change their activity very rapidly. Tumor infection. Always think of tumor and infection when a patient has pain, okay? Especially if the x-rays look normal. Location and quality. So this is a patient who came in with pain. I remember seeing him. It was a fairly young kid. I think he was 15. He had moved up to Boston from Haiti, and I think he was 8 when he'd moved up here. And he was having pain when he'd started playing football, and everyone had worked him up with everything. No one had gotten an X-ray. He came in, we got an X-ray, and I don't know if you can tell, but that's an abscess in his tibia right there. He had entire tibia was infected. So duration of symptoms, aggravating leaving symptoms, pain. Night pain's indicative of something worse, tumors. This could have been a tumor. We did obviously send pathology for that. Change in training, diet, all the same things here. So stress fracture, usually in adults it's the diaphysis, it's usually proximal in the tibia. Adolescents, it's almost always proximal, but again, adults it can be lower. Imaging, x-rays first, then MRI. If you have exertional compartment syndrome, I think I talked about that. You look at measure pressures prior to and after exercise. So again, changes in activity levels, repeated stress. It tends to be on the tension side of the bone, so it's usually anterior. Okay, they get microfractures in the bone. The bone doesn't remodel. Everyone can feel the front of their bone. Okay, the front of the tibia is very superficial. That's an interesting thing in that if you have a problem, a fracture, or that's why tibia fractures can be problems to heal, because the blood supply is so poor in that area. You need blood to heal bone. Okay, and bone remodeling, osteoclast. We don't need to talk about that. So treatment, usually it's non-op. This is just showing a non-union. Activity modifications. This was actually one that fractured that we ended up having to treat with a plate. It was a catastrophic fracture. He had been treated by his primary care physician. They thought it was shin splints, and it broke during a game. I think it was a soccer game. And it took forever to heal. That's the problem with these stress fractures is they don't heal as well as a regular fracture because it's already a fracture that has a problem healing. So they can be a problem. Pneumatic braces, compressive braces are one option if they haven't broken. Ultrasound is another option. So in this one we actually did do ultrasound and it healed. So this is just talking about leg braces. Basically what you do is you ambulate. So this study. So basically you get a stress fracture. You can either or shin splints. Either one can be treated in a pneumatic brace. When they can ambulate without pain, you can begin to advance them. Usually 5 weeks to return to activities. The ones that don't return are the ones that need operative intervention. So what can we do if we need to operate on them and they're not healing? So one of them is putting in a nail. Okay, we have to go through their knee. Everyone thinks, oh, we go through the knee, you have knee pain. You do for 6 months. After that, it's questionable the numbers of that. So the other option is anterior tension banding, which we started doing as well when I was in New York. Healing with plating, though, or nailing is less predictable. Again, these are hard to heal. With anterior tension band, they tend to have more likely to heal. And the tension band directly counteracts the forces. So what happens is they get a stress fracture in the front of the tibia or in the medial aspect, and every time they run, it wants to open. Okay. And so that constant repetitive stress, it's sort of a non-union situation. You put a nail in, you've stabilized it, but you haven't really done anything to change the fact that they're going to have that same tension. When you tension plate it, you're actually changing the forces on that tibia, and usually with grafting it'll heal. So this was a patient that had So it was Olympic level pole vaulter, 12 months of tibia pain. And this is what you see. All you see is a little bit of reaction on the front of the tibia. It's a little extra bone. Sometimes you can feel it, and you can sometimes see a little black line. They sought treatment when they were unable to ambulate. They failed conservative management. We tried ultrasound, rest. Ultimately, we went and we did the plate. There's a small plate. It's put on in tension. You tension this down right on the front, very small incision, and the patient went on to continue training with the Olympic team. That was 2 years later, and they healed by 3 months. Okay, so clavicle fractures. There's a healed clavicle fracture, but maybe not the best healing. Generally, conventional wisdom is that clavicle fractures all heal. Displaced fractures of the clavicle do well with non-operative management. Non-union rates are less than 1%. The only fractures of the clavicle that do not heal are the ones you operate on. So that was what we used to think. That's not necessarily the case. The current thinking is with new studies is that non-unions occur in 15 to 20% of patients. So about 1 in 5 patients that you see with a clavicle fracture is going to have a problem with healing, and about 1 in 5 is going to have problems with it will heal, but it'll heal in a bad position and it will bother them. And where does it bother them? It's usually in overhand activities. They get strength deficits. It's usually in overhand activities. They usually get fatiguing. So it's some laborers and athletes are ones who probably should have these fixed. Randomized controlled trials support ORIF fixation because it's early return to function, lower complication rates. Late reconstruction is not nearly as good as primary fixation. So if you miss it and they heal or they don't heal, and then you go to fix it, they don't do as well as if you just fixed it initially. So the mechanisms of injuries, children that are very young children, they don't need it fixed. Obviously, they heal pretty well and they're going to remodel. But as we get to adolescents and young adults and adults, that's different. Usually it's a fall on the acromion. It can be a direct blow in about 10%, and axillary transmission through the humerus in a smaller amount. So what do you look for on a clinical exam? You look for winging of the scapula. That can be an associated finding. You're going to see drooping of the shoulder. Okay, a lot of times that doesn't get better when they heal. A lot of the, as they call it, it's ptosis. You want to know if this is a sedentary person, if it's somebody, if it's a manual laborer, if they're an athlete, weekend warrior. These are things that are going to go into how you decide how you're going to treat it. This was interesting. This was a patient that we took care of that had been treated non-operatively, and this spike of bone right here, they kept complaining of, my hand burns, it's burning, it kept getting worse. This piece of bone was sticking into the brachial plexus. And we went in to take it out. We took it out of the nerve. And it's usually the ulnar nerve that bothers them the most. You numb this pain around the small and ring finger. So the question is, how do you decide who needs it fixed? I mean, so somebody did a study and said, well, if they're short 2 centimeters, you need to operate. And that's really great. So you get an x-ray and you go, oh, that's 2 centimeters. Well, we looked at this and we said, well, same x-ray, short 2 centimeters, you x-ray both clavicles, you measure them, and it's only short maybe a millimeter or 2. It's really, so that maybe that's not the indication. We don't know what it is exactly. Okay, I'll tell you what my thoughts are on what we do. What I do is if this comes in, this fracture, it's non-displaced, it's well aligned, that's going to get non-operative management. Okay, I'm going to get an x-ray every week, pendulums and Codmans for distal range of motion, elbow a couple times a day, 3 times a day, and weekly imaging for the first 2 weeks. By 4 weeks, I progress them to active assist, passive, gentle range of motion. And by 6 weeks, they usually have some clinical healing. They don't hurt, they've got callus. It may not be fully healed, but they can usually go back to doing almost anything they want. You can do progressive strengthening by week 8, therabands here at week 6, and return to pre-injury level by week 12. However, if it's a younger person and they've got callus from good callus by 6 weeks, you can advance some of this. So this is a good example. This was a 13-year-old right-hand dominant young gentleman, left shoulder injury during a tackle in football. He was placed in a SANE. He was seen in urgent care. And he came to see us in clinic the next day. And on this x-ray, it looks fairly lined up. Here, not so much. We started pendulums and Codmans, serial x-rays for 2 weeks. At 2 weeks, his pain improved. There hadn't been any displacement. In fact, it actually looked more aligned. And by 1 month, he had no pain. He was cleared to play after 2 weeks from then, at 6 weeks. So this is 13-year-old. He's back to doing everything. So operative management, same thing. I don't really do much different. The only thing is if we're going to remove the hardware, if it bothers them, although I haven't had any patients who've had a problem with that because we use fairly small plates, is 6 months is the minimum. If they want their plates out at 6 months, they have to get a CT scan to see if it's healed. So here's another 13-year-old kid, okay? Different fracture. You see, I mean, this is something, I look at this and I said, well, we could treat it non-op, but his shoulder was drooping. He had a lot of pain. He clearly had, you could see the deformity, and it wasn't in his dominant hand, but again, the deformity and the displacement, we gave the family the option. My recommendation was for surgery. You know, he was short here by about 1 centimeter, so the decision was made to fix it. So that's the intraoperative pictures. There it is, reduced. And actually, the really amazing thing is it was much more displaced than it even looked here. The bones weren't even close. In fact, the medial fragment was behind all of the muscles, everything. It was buried underneath posteriorly. So there is reduced. There's the front plate. There's the back plate. And there he is, healed, returned to sports at 2 months. I've seen him since then, and he has no problems. Cannot feel the plate. So this is something that you look at this, you can see this. This is fairly displaced. Clinical exam, shoulder height, visual displacement. Again, non-operative management, you look for your displacement. But someone like this with significant displacement, you take all this into account and you make a decision. Okay, throwing fractures. This typically occurs, professional pitchers, not so much. But professional pitchers generate 14,000 pounds of torque in their arm. However, those aren't the patients who get this. It's usually the weekend warrior or the patient who begins throwing and maybe starts too quickly. Javelin throwers, baseball throwers, shot put throwers, handball, hand grenades. Military personnel will get this throwing a hand grenade. Is male predominance, usually patients in their 20s. Recreational athletes are the ones that usually get it. It's usually a spiraling type fracture, usually because they have inadequate skills, they haven't practiced throwing, and it happens just by the act of throwing, the fracture occurs. So this was a quick case example. 24-year-old right-hand dominant gentleman pitching. He felt a pop. He played on the weekends. He had sort of it was baseball, but he played very infrequently. He also had a radial nerve palsy. He couldn't pull his wrist up. So we treated him non-operatively. He healed. You can see, there's some deformity. You look at this and go, well, that doesn't look so great. Maybe you could have made that better with fixing it. But clinically, he had no deformity. And this is why we don't operate on these, because, so you look at his arms, they look the same. You almost can't tell. That's it. That's 6 months, and there he is, full motion of the hand. So they do well. They look at you for 6 months and go, when's my arm going to start working? And it does. So, all right. That's it. Thank you.